안녕하세요, 김용진 원장입니다.
Greetings, I'm Dr. Kim Yong-jin. Today I'm going to talk about the merging protocol necessary to fabricate OneGuide template. In order to use OneGuide system, you need to follow accurate workflow. Workflow for digital guide surgery is the same. You need to take a CT and you need to get the surface data either by intraoral scanning or taking impression. You need to get scan data on information of tooth and gingiva. Once sent to the Osstem Digital Center, the two data are merged. In other words, DICOM file from CT and STL file from intraoral scanner or through model scanning are combined. This process is referred to as merging. After that, prosthodontic design process is proceeded, and following that, implant placement plan is set. Guide is designed and is sent to the dental clinic. CT needs to be taken first, followed by impression taking if you don't have intraoral scanner. You take impression, make a model, and you use model scanner to get surface scan data. Model scanning can be a very accurate and good method, but if you do this needs to be delivered to OneGuide Center via parcel delivery. If you do intraoral scanning, data can be sent right away. That is a benefit. Today I want to focus on merging of CT data and intraoral scanning data. DICOM file and STL file, which has been achieved through intraoral scanning or model scanning, should be combined so that we can get a three-dimensional volumetric file. A planning program is required for merging. In order to have accurate digital guided surgery, the merging process is extremely important. In order to fabricate Osstem's OneGuide, you need to utilize a 3Shapes Implant Studio. This is a high-quality, fancy interface program. If you take a look, CT data shows tooth contour accurately, and be it intraoral scanning or model scanning, you can see the contour of tooth accurately as well. That is the common ground. By doing a superimposition on the tooth, surface scan data is combined and prosthodontic design is done, and following that, the implant placement position is determined. As shown, workflow is like this. Model scan data and CT data. Instead of model scan, intraoral scan can be used. Let's look at how it is merged. As shown, the tooth position of model scan and the tooth position of the same tooth on CT, they're merged automatically by clicking on it, and guide can be designed. The guide is designed and 3D printer is used to print it out, and it's delivered to the dental clinic. Using this, implant can be placed. Today I want to focus on this. If the patient has residual teeth, we can merge based on the teeth, but when treating a dentulous patient, you may wonder what to do in placing the implant more safely by using OneGuide. In the case of fully dentulous patient, I want to talk about how merging protocol should be proceeded. I want to talk about what Osstem recommends briefly. As mentioned earlier, if the patient has residual teeth, you can do superimposition on tooth contour, but if the patient has no teeth, you can't do that. There's a couple of merging protocol in Osstem. First, you can use a radiographic guide. Second, you can use a radiographic marker directly on gingiva, or you can place orthodontic screw on alveolar ridge and add radiopaque marker on top. Radiopaque guide cannot be addressed in one visit. Preliminary impression needs to be taken with the patient in the dental clinic, and once you send the impression to Osstem OneGuide Center at the lab, radiopaque marker is applied to the alveolar ridge like this. Flowable resin or composite resin is used, and this serves the role of the tooth, and with this, model scanning is performed. With radiopaque marker on alveolar ridge, on top of it, the stent is fabricated. This is referred to as radiographic guide or radiologic stent. If you fabricate using this, negative impression is made, and you can use the same flowable resin to fill it up. On the radiographic guide or radiographic stent, the same radiopaque marker is applied. The radiologic markers will be in place as the guide is fabricated. This will be delivered to your dental clinic. If you use wax or material to register bite on top of the graphic guide and take bite, you move on to the CT taking process. The radiopaque guide will be placed in the patient's oral cavity, and once CT is taken in the radiographic guide, the positions here and the radiographic markers on the model will be aligned. These areas need to be merged, and accurate merging can be done. This will serve the role of the tooth. If you find the tooth visit cumbersome, then you can apply radiopaque marker or resin directly on the gingiva. In the case of upper, you can apply it in the palate or on top of alveolar ridge. What is important is that when taking impression or taking CT, these should not move, so it needs to be fixed on fixed gingiva or attached gingiva. You can address it within one visit, and it's not invasive, so it's a very good method. If you take a CT with these radiographic markers on, these areas will be aligned, and then impression is taken. Once impression is taken, on the model position, radiographic markers will be applied, and by using these like teeth, merging can be done. However, flowable resin cannot be fixated strongly on gingiva. Therefore, you need to use histoacrylate. This is medical tissue adhesive. By using this, you can fixate it. In the case of upper, as shown, if you attach it on the palate with a lot of keratinized gingiva or alveolar ridge, you can get the desired results. But what shall we do in this case? As shown, there is severe atrophy in the lower ridge, and alveolar mucosa is up to the alveolar ridge, and there is very little keratinized gingiva. Where should we do it? If you do it on top of movable alveolar mucosa, if you take impression, the radiopaque marker position and when CT is taken will be different. Therefore, you cannot use it for reference. In this case, you can use Osstem's orthodontic screw. The length of it is about 4 to 6 millimeters, and on the head area of the orthodontic screw, you can apply radiopaque marker flowable resin. The diameter range from 1.2 to 1.6, and you choose the shortest implant orthodontic screw. Yes, local anesthesia may be necessary, but this does not cause significant discomfort to patient. You need 3 points for mergings in order to prevent distortions in XYZ axis. Therefore, placement of 3 to 4 orthodontic screws are recommended. You use this driver to place the orthodontic screws. You do not prepare surgical engine and handpiece, so it's more convenient after placement. On top of it, on top of the head of orthodontic screw, you can fixate the flowable resin in the form of radiopaque marker. Then CT will be taken and impression will be taken. On the head area, the radiopaque marker will serve the role of the tooth, and accurate positions will be reflected on the CT. And when impression is taken, negative impression is taken, and once stone pouring is done, it will become positive form. You can use that tooth like a natural tooth and use it as a reference for merging, and that's my preferred way to go in the lower. When taking impression, rather than alginate impression, you need to use silicone impression material to prevent distortions. In these cases, if there's only 2 root rests, in this case, 1.2 or 1.4. If there's no fixation, you can use 1.6 orthodontic mini screw. You do not need to place it full depth. If you have fixation, you can stop, and then using flowable resin, you can add a radiopaque marker. I prefer making 4, although people say 3 to 4 are fine. Because if one of them does not have good fixation and cannot be used as reference for merging, you can use the rest of the 3. This is the case. In the upper, it's fully edentulous. There are some residual teeth in the lower, but there are metallic restorations. In the case of PFM restorations, when CT is taken, there can be metal scattering. Blurred images can come out. No matter how you can accurately replicate the contour of metal crown on CT, the accurate contour of the crown cannot be confirmed, therefore it cannot be used for merging. Although there are residual teeth in the lower and the anterior area, orthodontic screws were placed. This is pre-op image. 4 orthodontic screws were placed both in the upper and lower. Flowable resin was used to make radiopaque markers. They serve the role of the tooth. The order is important. You need to take CT first. If you take impression first, especially in the case of upper, orthodontic screws do not have high fixation, and as impression material is removed, it can also come out. If you have taken CT, you can just take it out and do stone pouring. If you have not done CT, then you would have to place screw again and take CT again. CT needs to be taken first, and then impression needs to be performed. If you merge it, the quality of it is excellent. If you look at the first part of the surgical report from OneGuide team, you can see the level of quality of merging. What is marked in green is that the distortion rate is less than 50 micrometers, so merging is excellent. Merging is an important step that we need to pay heed. Just like when we button our shirt, we need to do a good job from the first button. If merging is accurate, then the next steps of guided surgery will naturally become accurate as well. Last but not least, I want to talk about denture scanning. If you have intraoral scanner like Trios, you can do this. In the past, when OneGuide was introduced, the optimal denture that the patient was using was replicated, and a hole was made on the inner surface, and radiopaque markers like a departure was applied, and CT was taken again. The second time is taking CT on copied denture. CT's diachrome file will be transitioned to STL file using a special program, and scan data was garnered. However, you no longer have to do this. If the denture that the patient was using does not have metal frame, you can do merging with a denture. It's very convenient, so I'd like to touch upon it briefly. You can use the denture that the patient was using. If the patient's denture has metal frame, copying the denture is necessary because the CT is going to be taken. If there is metal frame, then a scattering can occur. You need to copy the denture first and print it out using 3D printer. You can either use a soft reliner or light body impression material and take impression. And on the exterior side, you add a resin bowl or radiopaque marker. You position it within patient's oral cavity, take a bite, and take a CT. Finally, you scan the copied denture with radiopaque marker once again. By looking at a case, you'll be able to better understand. In the lower, bold type over denture was used. In the upper, conventional complete denture was used. There was issues with retention in the upper dentures, so 4 implants were placed in the upper and implant over denture was applied. As you can see, there's metal frame, so there's scatter. If CT is taken as is, on CT, it'll be difficult to find the accurate radiopaque markers even if you add composite resin. Trios was used to scan the external and internal surface of the denture that the patient has been using. Copied denture is fabricated. If you have 3D printer, you can print it out very easily using that denture to make the internal fit better and to take impression of the alveolar ridge. Soft reliner or light body impression material is applied in small amount. After that, before that, you apply radiopaque markers on palatal and labial side. The labial and palatal side of the denture has radiopaque markers using flowable resin. By using tissue, conditioner like soft reliner or light body impression material can be used. You can trim the excess areas. Bite registration is done and CT is taken. The denture with radiopaque markers are scanned. External and internal surface as well as occlusal surface is scanned, and the OneGuide team can do implant planning using this. A CT image. If you look at this, the copy denture's plastic part is not shown, but the radiopaque markers are reflected. The denture with radiopaque marker was scanned again and used as surface scan file, and you can use this for merging. The OneGuide goes on top of alveolar ridge, so what should be done? The denture file with internal and external surface scanned, if you reverse it, the form of the tissue is reflected, and without taking impression, you can do merging and take impression of the alveolar ridge at the same time. The quality of merging is really excellent. If you have intraoral scanner, you can make a copy denture. If the denture does not have a metal frame and the fit is good, you can utilize that to apply it directly. Today, I've discussed the 4 possible methods we could use when we need to do merging to create OneGuide template for digital guided surgery in fully edentulous patients. For specifics, you can refer to digital master course or offline master course. By experiencing hands-on practice as well, you'll be able to get a better understanding. Thank you.